For our integrated video, we had case 1 with 4-month-old Angie. Angie presents with congenital muscular torticollis, possible developmental delay, and possible developmental hip dysplasia. To start, we're going to look at the ICF model for our patient based on the information that was provided to us. Starting with Part 1, functioning and disability, our patient presents with what was previously mentioned, the torticollis, hip dysplasia, and possible developmental delay. She also has limited cervical range of motion and strength. Some positive aspects in her body structure and function include intact sensation and negative newborn and infant reflexes. Some negative aspects that we found were limited cervical range of motion and trunk weakness. In her activities and participation, she's not able to roll or get onto her stomach to play with toys. Some positive aspects is that she's able to participate in daycare and does well with peer interactions. A couple of negative aspects is she still has difficulty feeding and breathing and has a little bit of a fever left over that is impacting some of her play. Environmentally, she goes to daycare most days and has mom and dad working outside of the house full time. She also has family support and lives with her parents and brother. She spends a large amount of time at daycare and not at home, which could negatively impact her condition. Personally, the patient is very happy and energetic. So to summarize our positive constructs, the patient is able to participate in daycare and have peer interactions to promote socialization with other children. The patient also lives at home with her supportive mother, father, and older brother. Family interaction support is important for typical development and rehab. Negatively, she's unable to roll onto her stomach to play with toys due to poor trunk control and limited cervical range of motion and strength. She also has difficulty eating, breathing, and that could possibly delay her motor development.
Hi, my name's Mikey. I'm going to be your physical therapist for the day. So let's just jump right into it. What brings you guys in today?
My child has had some issues rolling recently. She hasn't really been able to roll at all, and that just concerns me a little bit because a lot of the other kids at daycare her age are able to do that.
Okay. And with the pregnancy, were there any complications?
There were no major complications, but she was 2 weeks early. So we spent some time in the NICU. We were there for 2 weeks. She had a lot of issues with feeding. And so once she got that figured out, then we were able to leave.
Okay. Is she still having some issues with feeding or breathing?
Occasionally. I don't notice it that often. She sometimes has a little bit of issues with swallowing. But she's pretty much able to feed on her own.
Okay, good. And I also see here that she's on some medications. Can you tell me a little bit about those?
She's on Augmentin. She had a little bit of a fever, just a little bit of an illness and infection. And so we got her on some antibiotics and then acetaminophen as well to kind of help with that, that fever.
Okay. And looking at her hips, it looks like might be a little misaligned. It might just be how she's laying, but has she had any issues with her hips that you've noticed?
I don't think so.
Okay.
I'm not sure.
All right, well, that's definitely something we can take a look at.
Angie is on 2 different medications, the first one being Augmentin suspension, a type of amoxicillin. She's taking 45 milligrams per kilogram per day every 12 hours, which is accurate for her age. This is being used to treat an infection that she's presenting with. She hasn't been feeling well, and this is being used to try and fight that off. Some of the side effects most commonly are diarrhea, upset stomach, vomiting, skin rash, hives, and difficulty breathing or swallowing. Her tolerance to exercise may be affected to this in physical therapy, especially through that upset stomach or difficulty breathing. The second medication that Angie is on in taking is acetaminophen. She's taking 10 milligrams per kilogram orally every 4 to 6 hours, which is also appropriate. There are no major side effects for therapeutic doses, but we should be looking out for early signs of toxicity, including nausea, vomiting, diarrhea, and abdominal pain. If these symptoms do start to present, they are definitely going to affect physical therapy and her willingness to participate in any form of exercise.
We chose a potential developmental delay and tone as our top priority because of the patient's inability to roll. This may be due to the torticollis, but because we have a confirmed diagnosis already, we want to rule out the rolling deficit to possible developmental delay. We then chose the congenital muscular torticollis as our next issue to get baseline measures so that we can choose appropriate interventions and measure progression. Finally, we will evaluate the risk of developmental hip dysplasia. This is lowest on our priority because if we find a positive test, we will refer.
For possible developmental delay issues, we choose the AIM to evaluate Angie. The AIMS test grow infant motor skill to birth to 18 months. This test identifies delays in motor development and maturation over time. The AIMS evaluates sitting, prone, supine, and standing, which include rolling, is what Angie family is trying to work on. This test is also known breathing, which is allowed to compare Angie percentile rank among other children her age. We do not choose the Peabody because it focuses more on the reflex, locomotion, stationary, and it also could be too difficult for Angie, and it does not evaluate rolling. We found a bunch of studies that indicate a high degree of inter-rater and inter-rater reliability for the AIMS when applied to preterm infants aged from birth to 18 months. The high degree of concurrency validity was also found for using the scale, using the Bailey Motor Scale as a criterion measure. Compared to the Peabody, AIMS have a good concurrent validity. And for our case, we decided to measure Angie in the prone and supine position for the AIMS.
Keep it up. Keep it up.
To test for neuromuscular developmental delay, our group looking at the neck-on-body writing reaction and the body-on-body writing reaction, followed by some passive range of motion and primitive reflex. As you see here, the physical therapist is doing a rooting reflex, followed by a palmar-grasp reflex and the plantar grasp reflex, to looking at Angie primitive reflex development. She seems to not demonstrating rooting reflex since he is 4 months old, and this reflex should be integrated by 3 months of age. Followed by primitive reflex, we're looking at some passive range of motion to make sure there's no hypertonia, no spasticity, to rule any neuromuscular developmental condition that could prevent Angie from rolling. Followed by some passive range of motion, we're looking at the head-on-body writing reaction and the body-on-body writing reaction. Angie seemed to initiate a movement but could not complete a task. Therefore, our group think that Angie issue with rolling is more of a musculoskeletal issues more than a neuromuscular issues. For congenital muscular torticollis, we would like to measure Angie's cervical rotation and cervical side bending. The procedure includes doing passive and active with the arterial protractor to give us an objective value to help us with goal writing and the severity of her condition. We decided not to choose palpation as a test to perform because we do not want to aggravate Angie since it's the only first session and she may not be comfortable with us. Secondly, Angie is already diagnosed with CMT, and palpation might not provide us any more critical information that we need. To assess for the risk of developmental hip dysplasia, our group looking at the Barlow and Ottolini test. This test evaluates posterior subluxation and dislocation of the hip in an infant. It has a specificity and sensitivity of 98 to 99% and 87 to 97% respectively. We do not choose to use the asymmetry thigh or gluteal fold test because it's only based on observation, and these tests are also used to predict other pathologies.
Our PT diagnosis would be reduced left lateral flexion and right cervical rotation. According to clinical practice guidelines, neck passive range of motion is the most important in helping torticollis. We would want to stretch the SCM with low intensity, sustained, and pain-free motion. Football hold can be good for that. Trunk active range of motion is also important, so we would want to emphasize tummy time, rolling, and symmetrical playing. For rolling, we could put her in supine and use rattling toys to help facilitate rolling. Parent education is very important to help them facilitate exercises at home. We would tell them to stop the football hold if there are abnormal changes in breathing or if the infant is resisting. Relating it back to the ICF model, we can educate parents to have Angie's brother help with rolling and symmetrical playing. If either Barlow or Otolani are positive, we would refer out for hip dysplasia. Torticollis is the primary deficit, but if she still can't roll over after that is treated, we would reevaluate for developmental delays or try to find the primary cause of that. Conservative treatment typically responds well for CMT, and discharge would be when full neck range of motion within 5 degrees is achieved and there is symmetrical active movements and no visible head tilts.
Moving on to motor control and learning interventions, we're going to start off with passive range of motion. Passive range of motion and manual stretching remains one of the most commonly reported forms of intervention for CMT, with one new randomized control study comparing 2 stretching frequencies with infants younger than 3 months with CMT and passive range of motion limitations. One group received 10 sessions per day of 10 stretches each, and the other group received 5 sessions per day of 10 stretches each, and all the stretching parameters were held constant. Both groups had significant improvements in head tilt and cervical rotation at 4 and 8 weeks, but the group receiving 100 stretches per day showed greater improvements than the 50 stretches per day group. In terms of neck and trunk active range of motion, this remains one of the standards of care in combination with other interventions for CMT. Strengthening cervical and trunk muscles can be achieved through active range of motion during positioning, handling, carrying the infant, feeding, and through other exercises that isolate the weaker muscles. Incorporating riding reactions in upright, rolling, sidelining, or sitting postures has also been used effectively during treatment and daily care routines to strengthen the weaker side. The affected side of CMT is placed downward, elongating the tighter muscles and encouraging activity of the weaker, non-affected side. You can also position the infant in prone and encourage bilateral neck flexor elongation and strengthening the neck supine extensors. Using visual and auditory tracking to elicit head turning in supported seating toward the affected side can strengthen cervical rotation as well. In terms of environmental adaptations to the infant's environment can be incorporated into the home exercise program. Alternating the infant's position in the crib and changing the changing table position encourages head turning in the desired direction. Adapting the car seat position to promote desired active range of motion, minimizing the amount of time in a car seat and in an infant carrier, and placing toys on the affected side for the infant to turn their head have been recommended as a part of home programming. In terms of caregiver education, parents and caregivers should be educated about the importance of tummy time or prone play, positioning and handling to encourage symmetry, and minimizing the time spent in car seats and carriers to avoid further advancement of CMT. These strategies should be integrated into daily routines and home programs to enhance adherence. Finally, in terms of motor learning strategies, we chose discovery learning and guided learning to be a best fit for Angie. Discovery learning involves allowing a child to use trial and error to learn a new task, and guided learning allows a child to be physically guided through a task to accomplish a goal. Both of these strategies will be helpful for Angie to use her environment to her advantage, but also use the therapist or her caregivers to make sure she accomplishes the task.
So a couple of pain generators for Angie would be nociceptive pain, and this could be due to her infection. And acute infection tends to lead to inflammatory processes, and that could lead to general malaise and aches separate from her May diagnosis. And it could also be mechanical pain, nociceptive pain from the congenital muscular torticollis. Another potential pain generator is neuropathic pain, and this could be due also to the torticollis, and this diagnosis is often associated with a brachial plexus injury due to a possible breech birth. This can lead to an entrapment of the brachial plexus, leading to a possible source of pain. A few outcome measures with justification for pain in our patient. She is 4 months old, so we're more likely going to use the neonatal or infant pain scale or the neonatal facial coding system. The neonatal infant pain scale is helpful for patients 1 and younger for both preterm, in our case, and full-term children. It quantifies the pain on a 0 to 7 scale based on 5 behavioral characteristics. It also assesses breathing pattern and movement of the arms and the legs. And a study from 2012 showed that this is a highly reliable and valid multidimensional scale and practical scale with good clinical utility. In terms of the neonatal facial coding system, this is good for up to 18 months old, and it assesses the facial expressions of a patient during calm and painful situations. It has been studied and proven in a study from 2022 that shows that the neonatal facial coding system is a reliable and feasible assessment of pain in infants and young children.